Welcome to the Crescent City, where Vital Options is in New Orleans with ASH, the American Society of Hematology. Dr. Stewart, as we hear about the tissue collection and sampling, are patients throughout the country able to participate?
Yes, they are. I would encourage any patient that's watching to try and get involved in a study where either you can have your genome analyzed for your malignancy, or you can contribute to the cause by donating tissue towards a project like this. The current Myeloma Research Foundation tissue bank has many thousand samples in it already, gathered over the years from 15 or 20 centers, but the new Compass program is open at many more centers, I think.
How many? That's 75 in the
75,
US, Canada, and Spain.
And what happens to patients that are not treated at a cancer center but in the community?
Some of the centers are community-based centers. I forget what the larger ones are, and maybe you can.
US Oncology has a pretty big presence, and actually the majority of the sites are community. We have a VA partnership, actually Kaiser Permanente, I think, as well soon. A lot of the enrollment has happened at MMRC centers, big academic centers, because they're used to this, but we are seeing a greater uptick. So
I think as a general rule for a patient, it's usually quite good to get an opinion at a center that has expertise in your specific cancer. Even though your community oncologist will deliver the treatment, I think it's good to go to a center with specialized care, and those are the centers that will be able to do these kind of studies.
And also, clearly, what we have to take away from this is the growing role of the patient as a medical consumer, that the patient needs to own their disease and take responsibility to navigate their way and direct their care and seek out technology, because you have to be active, you have to be proactive.
I can't emphasize that enough, how important that is. In fact, through all of these organizations, LLS, Lymphoma Society, and MMRF, there are fantastic websites that can give a lot of direction and a lot of guidance to people where the clinical trials are being run, where these clinical studies are open, and even just to phone them up and ask, where could I seek advice?
And we already have clues from these older technologies where a translocation of certain chromosomes, 4 and 14, in myeloma affects about 15–20% of patients. Through retrospective analysis, we know that proteasome inhibitors kind of take away that adverse prognosis. Even at this meeting alone, we're seeing hints that newer agents, some of the IMiDs, may overcome some of the adverse prognosis associated with deletion of 17p or p53. So we are learning more, and it's important for patients to know, because in a cancer like myeloma and some of the rarer leukemias and lymphomas, the medical oncologists or even some hemoncs can't keep track of everything that's going on. So the patient should really know, what's my subtype, and how should I be treated, or at least ask the questions.
Reimbursement. What are the issues that you as advocates face? Are there problems for patients with reimbursement as we move into these new therapies? And also, when you do screening, the genomic screening, is that paid for?
A lot of what I was mentioning, sequencing, it's all research grade. So there's, in some cases, there are some panels like Foundation Medicine, and at least to my knowledge, there's not widespread reimbursement. Some patients will pay the $4,000 or $5,000 to get that done, but a lot of them are research grade. So through Compass, it's research grade. But then, things like FISH and conventional cytogenetics, those are, I believe, all reimbursed.
The problem is reimbursement is not uniform, right, and the out-of-pocket cost of patient is about $7,000 right now to get the full panels done. So there is a challenge until the insurance companies sort of catch on.
Thank you, all of you, because you are working in a most exciting time. We wouldn't have had this discussion 20 years ago.